Perfect.
Yes, absolutely.
All right. Hello, everybody. Nice to see y'all. Hope everyone's doing well. Just a few things. I won't take the entire hour. I thought my schedule was blocked for my patients later this afternoon, but that's okay. We'll get through everything. So we'll jump right in. But for the sake of time, at the end, if I'm running a little short, just shoot me an email if you have any questions or any comments, or if you want any educational materials or anything that you want me to send to you, just let me know by email in case I have to jump off at the end. All right, so we'll keep it pretty straightforward. We're just talking about some common sexually transmitted infections today. And we're focusing on just outpatient presentation and just going over a few first-line treatments of some common STIs and the importance of safer sex counseling for risk reduction. I'm not going to do a full, entirely comprehensive, in-depth dive into every STI. We don't have time for that. And these guidelines are based upon the recent CDC sexually transmitted infections treatment guidelines from 2021. There's and you can look this up online. There's like a nice MMRW or MMWR that they released, and they have like little pocket guides available and like a consolidated PowerPoint available that kind of gives you really quick guidelines on like treatments for different STIs. So for the common ones that we see, I'll touch base on them in this presentation. I'm not going to dive into things like PrEP or PEP really. Well, we already did an academic half day on that, but if you wanted to discuss that or had a question about PrEP or PEP or anything, or if you missed that academic half day that I did earlier, please just let me know. Just shoot me an email. Okay, so this will be really case-based, and I really try my best to pull from patients that I had seen or precepted this last year. So the first patient, I think we saw this patient a couple months ago. So it's a 44-year-old female patient who presents for a routine appointment. She denied any history of any STIs, but she did want to be screened for syphilis because she found out that her daughter was recently treated for a syphilis infection. Patient was really worried. She heard that syphilis could be transmitted from a mother to the child, so that's why she wanted to come in. So for this case, we provided her some education. The resident denied in terms of how syphilis is transmitted, and we reassured the patient, but we should absolutely get routine testing if she would like it. Her last syphilis screening was done 4 years ago, according to our ECW records. And at that time, it was negative antibody, negative RPR. Her review of systems was negative. She was feeling well, no other complaints. Her exam was totally normal. So this was the result from her ECW. I won't, you guys don't have to like call out your answer or anything, or just like read through the question, think about it. So you can see that her T pallidum antibody was positive. On the ELISA, the RPR screen was negative, non-reactive, and her treponema pallidum antibody particle agglutination test, which is another confirmatory test, was reactive. So given this combination and the fact that she had negative prior syphilis screening and denied any known history of any STI infection, what are these results most likely indicative of? So is it false positive or early latent, late latent, primary syphilis, previously treated syphilis, or unclear, more testing needed? So I want to copy and paste this test result because this is how you'll probably see it if you're ordering like the syphilis antibody cascade profile for our patients. And so it does kind of the confirmation testing for you in the reflex, which is nice. But sometimes it just takes a couple of days for all the tests in the reflex to come back. So just keep this question in mind. So for this patient, since both of her T-pal antibody EIA and her particle agglutination are positive, that does confirm that she does have an exposure to syphilis. And since she has, and the thing is, we don't know when she was possibly exposed. It probably was sometime within the last 4 years when her last syphilis test was negative. And since she has no symptoms at all, and her exam was normal, this would most likely be a latent presentation of syphilis. You can see this same serology in very early syphilis. Sometimes the RPR is non-reactive, they have positive antibodies, but usually you see like patients with some sort of symptoms at that point as well, which is not the case for her. So most likely this is C, latent. So to understand like the serology, if you're a little unclear on the interpretation, this is just a timeline graph of, like a line graph of primary, secondary, latent, tertiary syphilis and the timing at which different serologies are rising and falling in the blood. So I want to highlight a couple key things here to keep in mind. So number one is that non-treponemal tests, which the most common was the one we use, RPR. Notice that even in patients that are untreated, that can still wane over time. So you want to keep that in mind. Like for our patient in our case, her RPR was actually non-reactive. So it waned so much that it became negative, even though she was never treated. So just make sure that you don't accidentally miss a person that does require treatment. And also, if you look at towards the left part of primary syphilis and timing, the RPR and non-treponemal test, there is a delay. So if it's non-reactive, you could be also missing a very early primary infection, which I mentioned last slide. Treponemal tests oftentimes, not always, but oftentimes do stay reactive lifelong, regardless if treated or not. So I think a key takeaway point here to keep in mind is if you have a patient that has known history of syphilis and you're going to screen them, it's probably better to do an RPR test as opposed to, you wouldn't start with like an antibody, a treponemal test, because most likely that's still going to be positive. Of all patients I've seen so far, I've only had one patient that lost treponemal antibody because their syphilis was treated like over a decade ago, but that was pretty rare. So let's move on. This is the traditional algorithm that the CDC recommends for screening. So in this algorithm, you start with an RPR test, and you've probably seen this test in ECW. It's like your RPR screen with reflex to confirmation. So it starts with the RPR test, and if it's negative, it stops the algorithm and it comes back as negative. If it's positive, then it goes to like your treponemal tests. And then if that's positive or negative, you can follow up with the patient. But one thing to keep in mind about this traditional algorithm is, like I said before, your RPR can potentially miss latent presentations or very, very early presentations of syphilis infection. And so if you get a negative test, you want to keep that in mind. And there's that small chance that we could actually miss a syphilis infection. Because of this, one thing that we sometimes do is called the reverse algorithm. it's called reverse algorithm because you're actually starting with the treponemal test. So in ECW, if you type syphilis antibody cascade, that's this reverse algorithm test. And so you're checking to see if they have the positive treponemal test, which is the antibody. So like I said, the vast majority of patients with any prior exposure to syphilis should have a positive antibody treponemal test, and almost always it's lifelong. So if that's positive, then it reflexes to your RPR. And then you can follow the algorithm downwards from there. So some clinics do prefer the traditional algorithm. Some clinics prefer the reverse algorithm. Here at Ryan Chelsea, we do try to do the reverse algorithm, if we remember, only for patients with no prior history of syphilis. If patients have a known history of syphilis, instead of this reverse algorithm, we just send an RPR to see if it's positive or negative. And also, I mean, in terms of like cost of care, lots of laboratories are, some are preferring the reverse algorithm just because it's easier to do batch testing of lots of patients at a time. So it's cheaper to do and faster to do, because an RPR is more labor intensive to perform than the treponemal tests. Okay, I think enough on that. Let's move on. Okay, so you reviewed those results together with the patient, and she confirmed again she has no prior history of any STIs. You examine her again just to make sure she has no neurologic or ophthalmic abnormalities or symptoms, and everything's negative. So regarding treatment for presumed late latent syphilis, what would we recommend? So either penicillin once, or penicillin 2.4 million units once, or ×2 or ×3, or doxy 100 milligrams, and then that should be PO for 28 days, or penicillin GIV for 14 days, or no treatment indicated. So again, for the sake of time, I'm just going to go ahead, but it would be C. So you would treat this patient with penicillin G 2.4 million units ×3. That is the first line recommended treatment for this patient, given her late latent syphilis presentation.
Dr. Yan, there's a
oh yes, please.
Sorry if I interrupt you. Nadim is asking if starting with treponemal testing then is more sensitive.
It is slightly so. I'm so sorry, I don't remember the number off the top of my head. I read it last night and I forgot, but it is a little bit more sensitive, yes. And therefore, that's why some clinics are preferring to start with that test instead of the traditional cascade. If my brain pops up that number, the specific number, then I'll let you know. But good question, yes. From what I remember, I think it is a little bit more sensitive. This is pulled from, just to review the treatments for syphilis. So primary, secondary, early latent. You are going to, for adults, it's the penicillin 2.4 million units IM as a single dose. If you haven't seen it before, it's pretty big. It's 4 cc's, and you can see in that picture. So it's injected in the gluteus. That you have to give 3 of those, separated 1 week apart, though, if you're presenting with late latent syphilis, which is the middle row for treatment. So let's move on. Okay. So in her, this is maybe a little tricky, but how would you advise this patient regarding her follow-up testing? So keep in mind that she's presenting late latent and her RPR strain is actually non-reactive. So I think, so most of you guys know that like for RPR, for acute syphilis, you usually have a really high RPR and you're monitoring it to watch it decline. In this case, though, her RPR is actually already 0, it's non-reactive. So would you repeat in 3 months, in 6 months, would you repeat antibodies in 6 months, or would you just repeat RPR her next routine screening? And this I actually had to curbside one of the ID I think I spoke to Dr. Rahul Gaikwad, one of our ID attendings, because I wasn't sure, but the answer is D. So in this case, you actually would just presume that the bicillin ×3 would be sufficient, and presuming she had no symptoms to begin with, and you've ruled out clinically neuro and ocular syphilis, then you just presume that she's been cured. And so you would just screen her for syphilis at the next routine STI screening visit to see if she's like developed a new syphilis infection from another partner. So monitoring for primary and secondary, you repeat your RPR. The recommended intervals are 6 and 12 months. It does take a long time for it to decline. So tell patients to keep that in mind so they're not coming back like the next week to get repeat testing, because most likely their test result will not have changed. And it should decrease by 4-fold in a year. And if not, you're considering treatment failure or reinfection. Don't forget about things like ocular or neurosyphilis. For latent syphilis, your titer should decrease by 4-fold by 2 years. So, keep in mind, this is not applicable. It's not the same for patients living with HIV. This is for patients not living with HIV. So because of this kind of long delay in terms of serologic evidence that the patient has been treated successfully, getting a very clear history of their symptoms and potential exposures is important. And so you want to kind of know the timing of things, when this happened, if they had a rash at some point, when did it occur, and make sure that that's like documented, because sometimes when we are interpreting these lab results, we oftentimes have to call back the patient if their RPR kind of blipped up a little bit, to be like, did you have any new partners, any new potential exposures, et cetera, et cetera. Okay, so let's move on to the next case. This was, yes, this is a young 19-year-old female. She presents with abdominal pain. Pain began 10 days ago. Left lower quadrant does not radiate. It's constant. Did improve a little bit with ibuprofen. No fevers, chills, dysuria, hematuria, vaginal discharge, or rashes. She's had 2 new sexual partners in the last 30 days and reports receptive vaginal intercourse, but inconsistent condom use. She didn't know the status of the STI status of her partners. And she did have tenderness palpation of the abdomen and left lower quadrants. And pelvic exam, she did have some left adnexal tenderness, and she also had cervical motion tenderness. So I think most people are thinking this is possibly PID. So which of the following is commonly associated with PID? So is it Gardnerella, chlamydia, enterococcus species, streptococcus, or staphylococcus? So all of these are known to be potential organisms that can cause PID. But the first 2 are definitely your more common ones. So Gardnerella vaginalis and chlamydia trachomatis. Chlamydia in terms of, because chlamydia and gonorrhea are often implicated with PID of a bacterial cause, and your organisms that are associated with bacteriovaginosis, which would include Gardnerella, is your other most common entity. The other 3 are absolutely possible. They're just not as common. So in terms of minimum criteria to diagnose PID, per the CDC, it's cervical motion tenderness, CMT, or uterine tenderness or adnexal tenderness. So it's important to keep a low threshold to think about PID. Symptoms can be sometimes mild, but even mild cases, there is a chance of serious complications, including impact on the patient's fertility. Therefore, if you have even any one of these minimum criteria in a sexually active young woman, then or any woman with risk for STIs, you should make sure you have a prompt evaluation and consider treatment, sometimes empiric treatment for PID. There are additional criteria that we can pull up here. So that do increase specificity of your diagnosis, but does lower sensitivity. So oral temperature greater than 101, mucal purulent discharge when you're doing your pelvic examinations, elevated ESR, CRP, and documentation of infection. Most of these, the later half, the second half of these findings, though, they do take time. So if you have a high suspicion or even a moderate suspicion, it could be PID, you don't want to wait like a week for these test results to come back, especially if they meet one of the minimum criteria. You definitely can consider going ahead and empirically treating them. So what would that look like? So the guideline recommends first line would be ceftriaxone, IM plus doxy plus metronidazole, because you want to cover your most common pathogens. That would be the gonorrhea for the ceftriaxone, which covers your gonorrhea, doxy to cover chlamydia, and flagyl to cover BV organisms. So make sure that you patients are able to understand that they're going to be on multiple medications for those 2 weeks. For patients that don't seem to improve by at least 3 days, you may want to consider inpatient treatment. Sometimes we call them up and ask the patient if they're feeling better while they're at home. And if they're really not having any improvement by day 3, I have a low threshold to consider sending them to the ED. Make sure we're also screening for other STIs, including syphilis and HIV, and make sure that their partners have been informed and tested and treated. And you can presumptively treat for gonorrhea and chlamydia for his partners, especially if you're still awaiting testing results. Okay. All right, let's move on. Okay, so this, I think this patient came a month ago. So this was a 31-year-old male patient who presents with itching. So 6 months ago, he developed constant pruritus of the groin that improved briefly when he used like a topical over-the-counter cortisone 10. But then a week later, it came back, and then the pruritus spread from his groin to the axilla and the trunk. But he denies any skin ulcerations, no vesicles, pustules. He doesn't notice any discoloration of the skin, and there's no pain. And the itching is worse at night. And he brought in, I remember, a plastic bag that had like 5 or 6 different over-the-counter antifungals and other steroid creams that he purchased from online or from the pharmacy. He tried all of those without any luck. And so that's why I was presenting today. Okay, I have a feeling most people kind of know where this is heading. So we don't have this available, at least here in the Ryan clinics, as far as I know. Maybe Derm does, but you could do a Derm microscopy exam, and let's presume you did, and you see this fine little white line with a little hyperpigmented dark little lesion, I guess, at the end of this line. So people have an idea of what's going on. So this is scabies, consistent with scabies. So scabies is commonly transmitted from between sexual partners due to skin-on-skin contact. And that's why we categorize it under sexually transmitted infections. Obviously, this can also transmit without sexual activity, but it does take more than just like a fleeting skin-to-skin contact, like just a hug or a handshake is oftentimes not sufficient to transmit scabies. But prolonged skin contact, definitely, and fomites as well, so like bedding. Skin scrapings for diagnosis are oftentimes recommended as kind of your gold standard, but it's really not widely available. I've never seen nor done it here at the clinic. And some magnification tools, like I think the term is called dermatomicroscopy. I know some derm offices do have it, where you basically use a magnifier, like something that looks like a magnifying glass, and you're just placing it on the patient's skin to look for mites and burrows. And so you can sometimes, even without the magnifying glass, you can sometimes visualize little burrows and around skin flexures. So if you see that and the history sounds pretty consistent, and this patient had a very classic presentation, then you can presumptively diagnose and treat for scabies. Differential, though, to keep in mind would be things like syphilis or acute HIV, eczema, or seborrheic dermatitis in lice. So let's say for this patient, you do see the fine lines and skin folds in the groin and fingers, but you don't see any heavy crusted lesions or scaled lesions. The skin otherwise looks normal, just excoriation. So you treat them with permethrin, 5% cream. Patient applied it whole body, neck down, washed off after 8 hours. And then now he comes back 1 week later. And 1 week later for follow-up, he says, my itching's still there. I still have persistent pruritus. You repeat your exam. You don't see anything new. You did test them for syphilis and HIV at that last appointment. They're both negative. So what would you advise this patient? Would you repeat, do permethrin 5% again? Or would you say no additional therapy, come back in another week? Or switch to ivermectin oral, or switch to ivermectin topical, 1% lotion. So for truly refractory cases and alternative therapy for patients that don't tolerate permethrin, you can use ivermectin. Ivermectin, though, is not recommended first line just because there is higher risk of toxicity. And so for this patient, actually, the answer would be B, no additional therapy at this time, monitor for 1 week. You can offer them like an antihistamine to help improve their itching. Important thing to know for scabies is that oftentimes you only need a single application of permethrin 5% cream to resolve the infestation, but your sensitivity reaction, the pruritus, can last for up to 2 weeks. And this is because as the things that are embedded in the skin, like the feces and the eggs and the dead mites, they will still result in pruritus even after they've been killed off. So that itching will persist for some time. So a week is certainly still in that window where they could still have pruritus, but by 2 weeks, they should be improving. If they came back at 2 weeks or 3 weeks and they had zero improvement, then I'll probably do A, repeat permethrin 5% cream. Clothing and bedding gotta be decontaminated. So make sure that you tell them to wash everything, wash their bedding, wash their clothing, everything, and they dry it on a high heat cycle. Or you can do dry cleaning. Make sure that they're partners. So if they're any sexual partners are also with similar symptoms, they should be treated as well with permethrin. And keep in mind that if the sensitization to the mite can take several weeks to actually develop, so you may actually have a delayed onset of like the pruritus and itching after the mites have actually infested another person's skin. So like I say, antihistamines can reduce pruritus. And if there is failure therapy, especially for repeated cases, consider other mites or other diagnoses like allergic dermatitis that can also cause persistence of pruritus. Okay, all right. Moving on, next case. So 39-year-old male presents for a perianal lesion. 2 days ago, he noticed a small bump that he described near his anus. He had engaged in receptive anal sex without a condom a week ago. Last night, he applied preparation H because he thought it was a little itchy and he thought it could have been a hemorrhoid. And this morning the bump went away, but it's still itchy. On exam, he does have 2 small, shallow perianal ulcers, both just 0.5 centimeter in diameter. There's no bleeding or discharge, and he feels like they sting a bit when you're palpating them, but otherwise denies any other symptoms. Okay, so when we're talking about things like ulcers, so oral, anal, or perianal ulcers, the majority of young sexually active adults presenting with these symptoms oftentimes either have HSV or syphilis, according to the CDC data, monitoring surveillance data. Other causes that should be on your differential would be chancroid or granuloma inguinale or LGV, but these are less common. So HSV or syphilis would be the top of your differential, and you're oftentimes differentiating between the two on your history and exam and testing. For these types of presentations, though, it's oftentimes warranted to presumptively treat them upon their initial presentation. That's because for syphilis, it's highly contagious early on. And so just in terms of reduction and potential spread to other people, you'll want to treat the patient presumptively if their presentation is pretty consistent with the ulcer, a syphilis ulcer. And early HSV, HSV, as we know, is best treated early with things like Valtrex. So the earlier you have a window period to take it. So you're not going to wait for like a NAAT or swab test to come back a week later for treatment, because then they're already out the window. So for genital herpes simplex, for your first clinical episode, you can see like basically the regimen is like acyclovir, or usually we use either acyclovir or valcyclovir. For most of my patients, I use valcyclovir just because it's a lower frequency of dosing, so patients like that. And just please keep in mind that for suppressive therapy and episodic therapy, the dosing is actually different. I oftentimes don't remember off the top of my head, to be honest, but just know that they are different, and they actually are also different between oral lesions and genital lesions. So I'm not going to include all that detail here because I don't memorize it. I just make sure I remember to look it up just to make sure I'm giving them the correct course every time. And also, quick note is evidence does not really back up the use of topical antivirals. So I know there's like a topical, I think it's acyclovir. I'm not sure if it's what it's called, but that doesn't have really much evidence for it. So you do want to prefer these like oral regimens. So which of the following is false? HSV2 genital herpes is more likely to recur than type 1 genital herpes. Viral shedding of HSV2 occurs only during prodrome and outbreaks. Recurrent herpes outbreaks decrease in frequency over time. Pericoidal vaginal tenofovir gel decreases transmission risk of HSV1, and HSV2 genital herpes infection increases the risk of HIV acquisition. So the answer is B. So B is false. Specifically for HSV2 genital herpes, you can actually have viral shedding even between prodrome and outbreaks, and it's heaviest or most frequent rather within the first 12 months of acquisition of HSV2. All these other statements though are true. Excuse me. So things to keep in mind that you can counsel patients though is that the use of condoms or barrier protection and antiviral therapy can help reduce the risk of transmission, especially during this first 1 year after acquiring HSV2, after they have a genital herpes outbreak. The only thing to keep in mind though is if you had a patient that just for some reason had serology testing, and they never had any herpes outbreak lesion. They never had any ulcer lesions. They're just positive on serology. It's not recommended to prescribe them like Valtrex to reduce viral shedding. This really only applies to patients who have had, oh, that's okay, who have had a symptomatic outbreak. And this applies to patients that do not have a diagnosis of HIV. For patients that are living with HIV, it's a little bit different. Okay, so let's move on to another viral infection. So HPV vaccination. So let's do a quick review of Gardasil. So for Gardasil, you can start vaccinating at age 9, routinely ages 10 to 11 that are vaccinated. Gardasil 9 is the one that we're currently using in our clinics. It's a 9-valent recombinant HPV vaccine. And the only reason I'm really diving into a little bit of details, a lot of times patients will ask me like, what's the difference between 9 versus the other ones and what they cover and why. So serotype 6 and 11 cause most cases of anal genital warts, and serotype 16 and 18 cause about 2/3 of cervical cancers. It's one, and another question we often get is patients will come in older than the usual recommended age to be vaccinated, and they'll ask if they can get vaccinated. So immunocompromised patients, or those aged 15 to 45 without prior HPV vaccination, will require a 3-dose series. The only thing is, if they're aged 27 to 45, even though it is approved to be safe, you do need shared clinical decision-making to decide whether you want to proceed with vaccination or not. One reason to keep in mind is, in general, as someone is older, they've been potentially exposed to for additional strains of HPV, and therefore your benefit of vaccinating these individuals is less, especially if you were, say, going to routinely offer it. So it's not cost effective to routinely offer catch-up, quote unquote, catch-up vaccination for individuals aged 27 to 45. But if the patient wishes to proceed, another thing you oftentimes have to check is just whether it's covered by their insurance. Okay. For lesions of HPV genital warts, there are 2 kind of categories of therapy. The first is patient applied. The most common one that I've used to prescribe for patients is imiquimod. And the provider administered treatments, our go-to usually is cryotherapy, because we do have that readily available at some of our clinics. And cryotherapy and surgical removal is pretty commonly used for like intraanal, urethral, meatus, vaginal, and cervical warts. Sometimes if there's like extensive involvement, or it's in an area that can be particularly painful or very, very sensitive, I will refer them to dermatology for treatment. But if it's like on their hands or somewhere, then I usually just freeze it. Okay, let's go into my last case. So this patient I saw, so this is one of my patients that presented to the clinic here at Ryan Chelsea just last week. So these photos are not of him though, these are ones I pulled. But this was a 52-year-old male. He presented with 2 weeks of fatigue, loose stools, myalgia, subjective fever, and rash. He takes no medications and denies any past med history. He's up to date with COVID vaccination, and he just presumed he has the common cold or the flu. And so he really was here just to get a work excuse letter from us. He is MSM, and he noted 2 prior sexual partners in the last 3 months without condom use. His exam was totally unremarkable, and his vitals are normal except for the following. So I noticed that along his, on his face, he did have a little bit of flaking and some erythema, and it was symmetric, bilateral, and it also slightly involved his eyebrows as well. And on his arms and trunk, he had a very faint, like macular erythematous rash. So I think most people know where this was heading. So symptoms to keep in mind for acute presentation of HIV. You can have a wide range of presentations. So fever is most common, followed by lymphadenopathy, pharyngitis, but rash you definitely don't want to miss. And like I mentioned earlier, sometimes patients presenting with rash, even if you think it could be like syphilis, you do still want to make sure you get HIV testing done so you don't miss it. Things like myalgias are also common. Diarrhea, GI symptoms like nausea and vomiting, those are also not uncommon. And part of that is because as you are acutely infected with HIV and the virus is replicating at high levels, one of the first things it does, besides basically creating the reservoir in your tissues, is it impairs your gut mucosal barrier. So the cross-presentation antigens intraluminally and through the mucosa can cause diarrhea, loose stools like this patient had, and sometimes nausea and vomiting. So when we're testing for patients, the order that we oftentimes use is, I put a little inset here, is the HIV 1,2 antigen antibody 4th generation test. So our 4th generation test is our standard test, and it does reflex. So this can generate some confusion sometimes in terms of what this reflex is and how it's interpreted. So basically, when you click on this test and you order it, what we're doing in the laboratory, the first step is, and starting at the top, is an antigen antibody combined immunoassay. So it's a single well, and you're just testing if there's any reactivity for antigen or antibody at all. So if that's negative, it's highly, highly sensitive. So you've ruled out, for most cases, you've ruled out HIV infection. But if it's positive, it then automatically reflexes, and that's why it says reflex in the test. So the reflex will come back as a separate result, and that will tell you if it's HIV-1 antibody or HIV-2 antibody, either detected or not detected, or indeterminate. And I go over this in more detail for PGY 2 and 3 academic half day, but this is the general gist. So for this patient, this was the result from his labs that we drew that day. He had and you can see how it's the 4th generation is antigen antibody. It's a combined immunoassay, and that was reactive. And then a few days later, the reflex antibody then came back, and that came back with HIV-1 antibody reactive. So his presentation and his lab screening test results were consistent with the acute infection. And I then, the viral load oftentimes comes back another week later. So just this, I think this was from yesterday, his viral load came back obviously very, very, very high, which you do see for acute presentations, and they are acutely ill and very symptomatic. And you see his CD4 count was 123. So I called him and we started him on Bactrim. So one thing to kind of start to wrap up. So sexual history is obviously super important for our patients. It's important to understand patients' risk factors, such as their prior STI history. For instance, regarding the first case, was a patient ever exposed to syphilis or not? The type and number of partners, any history of transactional sex, which is sex in exchange for money, housing, drugs, or other things, and the STI status of their partners. And this goes hand in hand with safer sex counseling measures. So that means communicating with their partners, consent, counseling on reduction or avoidance of substance or alcohol use during sexual activity, carrying barrier protections, whether it's female or male condoms, or dental dams, getting routine, excuse me, drink of water. Getting routine STI testing regularly done, making it a common part of your annual physical exams. Also notifying partners as well. So, if you're only treating the patients, but we're not kind of treating any partners, then they can certainly be re-exposed. And so make sure you let patients know to be notified. And also for reportable diseases like syphilis or gonorrhea, chlamydia, the Department of Health sometimes also follows up and will call patients and inquire about any potential exposed partners. So like I said, just make sure that obtaining a sexual history is a routine part of your social history. And it is important for everybody, no matter what your demographics are, but it's especially important in patients with an increased risk for STIs, which I think goes without saying. Okay, all right. With just like a minute to spare, thank you all for your attention. I do have maybe one quick minute if anyone has a burning question, but otherwise, please feel free to email me at any time.